All right, so there's no way I'm going to come down to on the side of that checklists are not important. I mean, I think that pretty much everybody could agree that they are. So this presentation is really about how effective they are rather than are they effective. But it'd be great if somebody could call in and argue about that. That'd be great. Or if somebody in the audience wants to argue about checklists being a bad idea, that's fine. We can talk about that. But if you think about some of the things that we do, we build, not we, but people build an 80-story building, and the tensile strength of the steel is correct, and the windows don't fall out, and it works. In fact, the chances of a building collapsing, an 80-story building, is 1 in 50. What do I have here? 1 in 50,000 buildings collapse, and that's because and that includes with earthquakes and everything. And the reason is checklists. I mean, everybody along the way, the architect and the people building the building and the people doing every detail of it are following checklists. And the way that complex tasks can get done, such as flying an airplane, and that's another good example, your chances of dying on a commercial airline are only 1 in 29 million. That's pretty amazing, because that's a very technical thing to do. There's people fueling the plane. There's people doing the safety checks. It's all checklists. So that's how checklists are related to industries that are not ours, like perfusion and medicine. But there is a very good example of a book that was written. It's called the Checklist Manifesto. And Dr. Atul Gawandi is his name, and he started looking at checklists, and he's the one that actually brought checklists to the operating room, something that we're all very familiar with the timeout that we do, before we do a surgery. So he did a study. He works at Brigham's and Women's General Hospital in Boston, and he's a general surgeon and also an endocrine surgeon. And he did a study where they had a control group where they had no checklists, and then they did a study where they had a group of patients that were they used a checklist, and the results were amazing. So just these numbers are really out there. Complications due to avoidable human error went down by 36%. 36%. Wow. And that's a big hospital there too, so that's a lot of people. Deaths went down by 47%, so half. I mean, that's absolutely amazing. And this was due to checklists. These checklists were written by the nurses and by the doctors themselves. So they made up their own. And he puts out in the book, he puts out some guidelines on checklists that they should be short, they should be one page, there should be a time that the checklist should be done. It's got to be laid out when the checklist is going to be completed, and it has to be quick and it has to be one page. So do checklists work? Definitely they do. And there's definite proof of that. So because of his book, and I'm not trying to do a book report, we are going to do a project here together in just a second, but because of his book, the World Health Organization started recommending the idea of using a surgical checklist, which we've seen this. Now the one we're familiar with is that they recommend 3 parts. That there's a sign-in that's before induction, and Vicky's here. Do you do a pre-induction checklist for your patients?
Yes, we do.
You do, okay. So I've never seen that before, but what we all see is the timeout, and then there's a sign out that before the patient leaves the room, which again I have never been involved with that. Only the timeout is the part that I've been familiar with. So the main thing about this is that checklists are very important for mundane tasks, because something that we do every day, we can actually lull ourselves, and these are just some quotes that jumped out to me, while going through this book. When you do something every day, you can miss important parts, and when you've got somebody's life in your hands, you really don't have there should be no option that you actually go through the checklist and you look at the items. And I'll tell you, I have used electronic charting in the past, and the software that I was exposed to, believe it or not, you could go through the checklist, the pre-bypass checklist, and you could check each thing off, or there was a button that you could say yes to all. And it would go through the whole thing. And that's what we all do in our minds. Not all of us, but a lot of us do that when we're, getting ready to go on bypass. We go through our checklist pretty much in our head, and we don't actually go through and do it. And I'm pretty sure everybody is guilty of doing that sometimes.
Not me.
Not you? So when you
I do
when
all my
you
checklists.
when you read it,
I keep all my
you go and you
laptop.
look at it. That's great, and we should. And I'll tell you what, it was a case that you did the other
Yes.
day. You went through the checklist and you found something before you went on bypass. Remember
I
that?
couldn't remember what it was, but
It was
yeah,
it wasn't a big deal, but it was a
wasn't a big
sucker in
deal,
the wrong place.
correct. Oh, that's
It
what
wasn't
I found.
backwards
Yes.
or anything. but
It wasn't
was,
backwards. It wasn't deleterious. But the fact was, I used the checklist to find it. It was in the incorrect raceway.
Right. No big deal, but
It was
it
no
could,
big
it could have
deal.
been worse.
Correct.
So
Yes.
you're doing your checklist. That's good.
Yes.
So just a couple quotes. So whether planning to go to the store to make a cake, preparing for an airplane to take off, or evaluating a sick person in a hospital, if you miss just one little key thing, you might as well not have done this project at all. Because the check, and what really jumped out about that to me was, I love cooking, and I know you do too, actually.
Absolutely.
And you make a list before you go to the store, and you make sure you have everything. That's a checklist. It's a task list too, but there's not a
Right.
lot of differences between a checklist and a task list, except for a checklist is something that's the same every day, and it's to attack mundane. Not that perfusion is mundane, but it is a task that we do every day, and we can be lulled into a sense of safety. And believe it or not, this study showed along the way that you can actually think that you've done tasks and check them off on the checklist, but you really haven't done them. So checklists are important, and that's my point. So what I really wanted to talk about is, as perfusionists, where should we be using a checklist? And I think everybody is familiar with a pre-bypass checklist, and we use it. So that's item number one. But what I'd like to talk about, and hopefully some people will call in, or we can have some chat on the YouTube chat, should we ever have a handoff bypass checklist? How many times have you given somebody lunch and you sit down and you take their place, and there's a clamp somewhere that you don't normally put a clamp, or there's a button, whatever. There could be a number of things, and I've experienced it. And I think you have a story about that, don't you, Joe? You took a case over, or somebody took a case
We'll put that
over?
in the discussion period.
Sure, okay.
It's a little bit of a long story, so I don't want to interrupt your flow. Let you keep going, but remind me about it, because it's a tragic story too. So we'll talk about it.
Well, this is my last slide. I mean,
Okay.
I wanted to go, what I wanted, and the other idea I had for checklists is that, some people are using termination of bypass checklists, and I think those are a good idea. There's only a few items that I would think of putting on there, but the handoff checklist, it'd be interesting to know how many problems there are when there's a handoff. And you think about if you're, at the ICU and you're watching an ECMO and you see a nursing shift change, they go through a process, and it takes about half an hour for them to go through handing off a patient. And I'm not saying we should take a half an hour as a perfusionist to give somebody a bathroom break or something, but I think there should be some things that we check off that we've looked at. Mm-hmm. Where are we at? Are we warming? What drugs have we given? What are the allergies of the patient? That sort of thing. So my idea was that if what we could do is potentially build a checklist together. So if there's people on YouTube chat, or if there's anybody who can call in, what are some of the items that we would put on that checklist?
That'd be great. Yeah, you got the call-in number up, already, and we'll do that. And I think it's great. So do you want me to tell this story?
Yeah, I'd love to hear the story.
I think you're really on point here. I think with something is that we generally don't give much of a report when we're relieving somebody. It's kind of like just, where you at with the operation, and then that's it. And we all do things differently. We do things the same, but we do things differently.
Right.
Where clamps are, like you said,
Sure.
or what's going on were you having trouble with the pressure or not? I mean, there's so many things. If you did a full report, it's going to you have to come earlier for that break time. I think there needs to be probably a little bit more time associated with it. But there are some people, let me just throw this out, maybe somebody will have a comment on YouTube or call in that people that advocate you should, if you start a case, you finish a case. You should never be relieved. And so there are people that believe that. I don't know where do you come on that?
That's mostly how it's been for me. So I have the bladder of a bull, and I can do cases all day and not have to take a break.
Right.
But it's so nice to have a break when it happens, and so I'm not an advocate of that. I don't think that's realistic, but I know it's the reality in many cases. People work alone.
Yeah. You worked in a situation when you were working in more of a single place institutionalized environment. What was your experience with giving breaks?
But we had backup. Yeah, absolutely. But see, we would never utilize it. Or at least I wouldn't. And it wasn't frowned upon, but we just didn't really access it because it's again the continuity of care.
It kind of was frowned upon.
It was frowned upon.
Yeah.
It was. Let's just say
what? You need a break?
Yeah, right. It's kind of that Iron Man mentality. I mean, but nonetheless, I mean, it's a continuity of care. It's not. It shouldn't be a demonstrative type thing or just like a view on you can't do a case by yourself. Yeah. But it's a continuity of care thing.
But I'm sure that there is an inherent added risk when you hand a case off to somebody. I mean,
absolutely.
There absolutely is.
Yeah.
No kidding. And I think that is a big problem. So not just on the bypass period. Okay. So even though we have this issue of we don't want to return the case over. Okay. We're going to finish the case. We come off pump. But, it's time for you to go and you've got an appointment or you've got a date or whatever it might be, and I need to go, and somebody comes in after you're off bypass kind of to close for you, so to speak, okay?
Yeah.
So this is what happened. It was a pediatric case. They I
don't know if I want to hear the story.
Yeah, right.
I do want to hear the story.
Yes.
And I think this has a lot of lessons involved in it.
Okay.
So the perfusionist was going to be relieved. The relieving perfusionist came in the room. The perfusionist who had done the case said, "We're done. All you need to do is clean up." He left. The perfusionist that was relieving took it literally. Took all the clamps off of the pump.
Cannulated?
And started throwing it into the trash can, but the baby was still cannulated. So as you can imagine, the outcome was poor, and it destroyed 2 careers. And it's one of those. It's basically what you're talking about.
Yeah.
We don't have a handoff checklist. We have a pre-bypass checklist, but we don't have a warming checklist, a cooling checklist, a what to do if it's an emergency checklist, a termination of bypass checklist. We all know to kind of look and see, is the ventilator moving? And if it's not, are we breathing? Say something pleasant so that it reminds them, as opposed to, turn the ventilator on, idiot. We try not to do that too often unless we don't like the person, I guess. But, nevertheless, when we're being relieved, we sort of give, and everybody does it differently, and the information that's transmitted is not uniform in any way or consistent. It's going to be different each and every day with each and every person, and I think that those kinds of problems can occur. So why don't we do this exercise? We'll just do it together, and nobody calls in. So far, we haven't gotten a call, but let's just do it together. What should we look at?
Is there a way for you to make a document to keep up with what we have?
Do it right now.
Well, so I'm going to have to picture the situation. I don't have a pre-formed list. I thought we would come up with it as we go. So I would say, let's say you're going to walk in and you're going to relieve me. Already, I tell you, where we're at in the case. I say, this is coronaries, the distals are done, and we're probably about to start warming. That's about all I say. So I guess, first off,
what would I like to know?
What kind of case is it, and where are we in the procedure? That would be item number 1.
I want to know something about the patient.
Yeah.
What is this patient? What's this patient, condition? Is this a small patient, a big patient? What's the size of the patient?
Sure. Well, that's on the chart, or that's on your
patient.
pump
Have
record.
you given any transfusions? Have you I mean, this list could start getting really long, and I think that's really the issue.
Yeah.
Let's do this, and I'm going to try to do my best with this, as best I can anyway. But again, we have a nurse in the studio audience. Let's ask the nurse. Is there a specific set of things? And now the nurse is eye rolling, and I can see it. Okay. Let's ask, what do they do when they are changing shift?
That's a great question. It is a very good question. It is.
On the spot here, I don't have a list in front of me, but it was similar to the things that y'all were just describing. Number one, the procedure, the patient, where you're at in the procedure, because that has a lot to do with how long the patient's gonna stay asleep, and what kind of medications you need to give for reversal, or do you need to start turning your gas down? Where you're at in the procedures.
I'm talking more
important.
about the ICU. I'm
Okay.
talking more about the ICU. So,
I think it, your same thought process transcends the location that you're at.
Okay, fair enough.
Your basic
accept
your
that.
basic question. I mean, your basic request of what you want to know is tell me something about the patient.
Mm-hmm.
What's how old are they? What's their and I know it's usually always written down on whatever record that you're immediately working on, the day's record or the procedures record. And you can briefly just, pass through all of that. But and that's not going to change their age, their diagnosis,
Right.
All of that. But I think what's going on right now, where their drips are at, what different medication they're on, what's in line next to happen. Do they have labs that are due? Do they have Accugen? All of the things that they're gonna immediately need needs to be communicated.
Mm-hmm.
So I guess the first item on our list would be, you have a list going. That's good.
He does.
Where are we at in the case? I think that the stuff I look over, I hate walking into a case in the middle of it, honestly.
Mm-hmm.
I really don't like that, because you don't know.
I don't either.
You're not
don't have the feel
tuned
for it
into
either.
it. Yeah.
Right.
As perfusionists, I think the same thing with anesthesia. We have a feel for the procedure.
Right.
We have
Yeah.
been on pump for an hour and a half, maybe 2 hours, or if you're getting relieved, 4 hours, and you definitely have a sense of what's going on with this
Right,
case. And you walk in cold on that, and it's like it's hitting you all at once, and it's very hard. How long does it take for you to do a change in staff, either in the ICU when you're caring for patients there, or in the operating room when you're doing anesthesia? But try to extrapolate that into higher acuity patients, more like heart patients, or major vascular procedures versus, a hip replacement.
Well, I think the sicker the patient is, the more that's going to be going on with them, and the longer it's going to take, because you have more to communicate. If you're in a healthy patient, elective surgery, then there's not much to communicate with them. They don't have all of these extra diagnosis to have to go through. You have a 20-year-old that's having a knee scope, then it's it's pretty quick. It's just what's going on with the procedure. In ICU, they're sick patients, and they have a lot going on with them. And like Rodel was saying, it takes 30 minutes, and it's a process.
Mm-hmm.
It's because you don't want to leave anything out.
Right.
Mm-hmm. Mm-hmm. So it takes so you're saying it takes 30 minutes.
I think it can.
So it can take up to 30 minutes, basically, is what you're saying. So it could take 15 if the patient is basically just sort of on autopilot, post-op heart, they've been extubated, They've got a little bleeding out of their chest tubes, but
Well, and that's if nothing's going on at the time. It may be that you start report, because if you're talking about 30 minutes, you may have to stop and you may have to do something, and then you may have to come back to report and then stop and do something again, and then
Right.
it may take it. And usually you would have two patients, so you're you could get out of there 30 minutes, an hour late a lot of the times.
just trying to get report.
Yeah. Yes.
Right.
Exactly.
And that therein lies the, nursing is tough business. I'll tell you what.
Absolutely.
It's tough business. Perfusion is a tough business. CRNA business is a tough business. Medicine is tough, I think, anymore. I mean, it's just so complex, and we're doing so many different things that the idea of out by noon with no balloon or leaving on time,
Right.
On your shift is just something that doesn't happen. You think that's is that a newer phenomenon, or has that been basically going on for a long time? We're all pretty old here. My recollection of things is that's been pretty common over all of the years that I've been in this. You have any experience with that?
No, I think it's been pretty common through time.
It's not anything new.
Right.
Yeah.
Yeah. Nothing new.
So, this is what I wrote down. For
Yeah,
what
I'd like to see what you have. Is that something that can be
So I
shown
need to
too?
share this online, so hold on a second. Roger, do I need to be on the Mophie? Okay, so I'm gonna switch to that. Okay.
And I'm thinking kind of
And then I have to
technical, like
restart the software.
look over where are clamps, what's the
Yeah,
vacuum
right.
at? If there is
Oh, I have to
vacuum.
restart. Okay, it's on.
Where is the patient cannulated? There's a lot of
I'm on
things.
There's a lot of things.
Yeah.
And there, do you see it?
Yes, we can.
It'll take 20 or 30 seconds for the
Yeah,
web
to pop up.
but it'll pop up. And I can change it while we're sitting here
Right.
and do it right now.
So what do you have on there so far?
Well, let's wait until, let me know when it's up. Is it up?
Yes, it should be in the room as well.
There we go.
Okay, good. There it is. Okay, so where are you at in the procedure? About the patient, the demographics and the labs and other information regarding the patient's condition. What the patient's need for medication has been or will be. What's currently happening. What are the drips and meds that they're on? What are the hemodynamics? What are the labs? Have they received any transfusions? Do they need to receive a transfusion? So that's
Yeah.
what I have so far.
So basically, it's conveying your care plan
Yes.
to the next perfusionist or whoever the next clinician is
Mhm.
is going after.
Well, could you see that list? Do you have anything to add to the list? Let's create the list, and
Well-
then it'll be forever on there. And some people can add to it. Maybe they can add comments to the YouTube video later because it's always up.
Yeah.
And they'll be able to look in there and make comments. And actually, people have been commenting on a lot of our stuff
Right.
later. So they might not be watching it live and wanting to contribute right now,
Right.
but they can do it later.
Those are good things, but I think that the list should be pretty specific. I think it should say, have you checked where any clamps? Just look at all the clamps. How many clamps are on the bypass circuit?
Right.
Is the cardioplegia line clamped? Who knows what's clamped? It depends on who you're relieving. Is the
Right.
vacuum line clamped?
Right.
So where are clamps is pretty specific. I would say, and what's the ACT and when was the last ACT? That's important.
Right.
And when was the last heparin?
Yeah.
Right.
Less
And this is stuff
administration.
you can look at. We could generalize that and put that, have you looked at the chart?
Temperature.
Oh, temperature. Yeah. Are we warming? Are we cooling? Yeah, that's a good one.
Yeah, because if it's been an hour since the last heparin and the last ACT was 20 minutes ago, and we've already heated up from 28 degrees
Sure.
to 36 degrees, we may want to do an ACT right now.
Right.
I mean, I don't know what your guys' level of charting is, but Patrick has seen my chart. And
He's a good charter. He's a good charter.
Well, and it's funny. I write down very important details, and I will go back to the next perfusionist, or if somebody needs to relieve me for some weird reason. I like to finish my cases. I will actually go over every single piece I've documented, and talk about my care plan and things like that. So we are discussing everything that's on this list. So from temperature all the way down. So like, hey, this is your CRNA, this is your anesthesiologist. This is not your normal CRNA. They're just giving a break or things like that. I mean, I'm going through everything, even all the way down to personnel. I'm kind of detailed when it comes to that. I really don't like giving up cases, but if I have to, I'm giving them every piece of information that I am trying to collect and return it to the next clinician.
I think that's the safest way to do it. But let's go back to the pre-bypass.
I think add personnel to your list, because I think that's that was an
Right.
important
Add what?
Personnel who
who were the people in your room.
Yeah,
Is that 2 ends or
that's 2 ends.
personnel in room? Okay.
I mean, I think it's probably more common. Most people, and I'm with you, I would prefer to finish a case, and if I really need a break, take it right after we get off bypass.
Right.
But there still should be that checklist, because what happened, what the story you told. I mean, you were off. Whoever the perfusionist was off bypass, and they said this case is done. They left.
All you
And
need to
then
do
the
is clean
patient-
up. See, that was the key.
That
Yeah.
was the key. I know this story. I've heard this story.
So, had there been a checklist, even though, so it's not only when you're on bypass, it's after bypass. I mean, it's certainly a critical time for the patient
Absolutely.
at that point. So maybe even more critical than when you're on pump. So, I think a checklist like this would be very helpful, to us.
So why don't we do this? Why don't we commit to this? Why don't we, over the course of the next several weeks, months, whatever it might be, start developing this as a routine item to have and talk about it, and do this again where this is the actual topic. Maybe do it during the weekday. I think sometimes during the weekday, I'm trying to figure this whole thing out. It seems like we might have better participation during the weekday, people calling in, than during the weekend. Though we look good. We did pretty good today. Like to do better. Pass the word on if you're watching, Claire, John, whomever. It'd be great to have more people calling in and being a part of this process. But maybe we just need to do this. You're talking about specifically a change of clinical staff checklist.
Right.
And why don't we just do that and redo it and redo just that part?
Yeah. Actually, I also think you mentioned it. We were talking about charting. We could do an episode and maybe include it on this one as a chart review.
Yeah.
Look at some people's charts, not mine.
My
And,
handwriting is terrible.
And talk about, what should be charted and what isn't charted. I mean, there's a lot of debate there.
But are there
And with electronic charting coming,
right,
Right.
of course. And
This is
are there standards for that?
Yeah.
And the thing about the electronic charting is, that's a whole other topic, but that costs money.
Oh, absolutely.
Okay, electronic charting costs
not
money.
cheap.
It's
Yeah.
just like EHR, EMR that currently exists. But the thing is, the physicians who sign up for it, the hospitals that sign up for it, all these people that sign up for it are given these huge chunks of money to do it. But we're not given anything.
Nope.
Yeah.
But yet it's much more expensive. I mean, these things, you used to work for the company. How much,
Yeah.
I mean, it doesn't matter what company it is. How expensive are these things?
It depends on how many machines, how many pumps you have and all that. But basically, it's going to cost $50,000 to set it up and get it going.
Wow.
And then a lot of the companies will charge you on a per case basis. And that'll range between $40 to $100 per case.
Password to continue.
I don't know what happened there. So it's expensive. I agree with you.
I didn't recognize that.
I'm
Could
just
you
going
tell
to
me
turn
your
this
password?
off. I'm not going to tell anybody my password.
Tell 'em,
Are you
tell
guys
'em.
televising
Yeah,
this?
it's just the World Wide Web. It's just internet. It's just between us and the internet.
That's right. Okay. Anything else we want to add to this list while we're thinking about it? I think because We're a little bit early, but I think it's going to be okay for us to probably, we've had so much, we didn't take breaks, we didn't do anything. It's been really packed full. I think ending a little early today is probably not going to be a bad thing, and it'll help with you getting to relieve Stephanie. Stephanie, if you're still watching, please again, forgive me. I'm not sure which camera Stephanie is in right now, but I'll look at all three. Please forgive me. I will never plan having our faculty be on call ever again. That was